Good afternoon. So it's my pleasure to be here speaking to you among so many friends and colleagues. And I'm speaking to you from the perspective of an academic researcher, I guess. So I'd like to start by thinking about, if we're talking about a research agenda for population health improvement, well, what does improving the health of populations imply? What does it necessitate? And to me, it's two big things, which won't be new to you. One is shifting population patterns, modifying distributions, shifting distributions, changing the shape of distributions, and lowering risk overall. And the second big piece which is fundamental, is reducing inequities by class, race, ethnicity, gender, place, et cetera. So these are the two things that we need to do if we really want to improve population health. Of course, it's also important to think about, well, what does this, quote, population health approach imply? What's kind of the philosophy behind it? And I think this is a good starting point, too, and this won't be news to you either, but I think it's worth restating because it does affect the way I'm thinking about the research agenda. First is certainly that we have to consider multiple levels of organization, from society to cells and genes, that we have to think about how social and biological processes interact over the life course, that we have to have an explicit concern with health inequities, and that we are also explicitly concerned with policy and practice translation in everything we do. And so these four, I think, themes, which to me are sort of the defining elements of this population health approach, are important to keep in mind as we think about what are some research priorities. And just to emphasize, to me, at least to me, this population health approach obviously encompasses the individual level factors within the purview of classical clinical care, but also broadens them and considers their upstream determinants. So we're not excluding individual level or clinical care-related factors, rather we're putting them in context. So I thought I would do this by creating a sort of typology, and this is obviously my typology, of types of population health research, and talk a little bit about sort of what I think we've done so far in each of these, and what are some promising directions to explore further in order to advance our mission of improving population health. And I've come up with four. One is etiologic, and I emphasize etiologic research in the broad sense. The second is mechanistic, and I put in parentheses there, legitimizing, and I'll explain this a little bit more when I talk about it. I'll just say briefly that I think a lot of times the mechanistic research that we do is fundamentally about legitimizing causal inference, because we can tease apart. I mean, it doesn't necessarily yield a lot of new insights, but it helps us explain better why things occur and legitimizes perhaps some of the causal relationships that we're making inferences about, which to people might seem counterintuitive, or how could that thing that happened so long ago be important to my health now? Well, if we have a biological mechanism, obviously that strengthens our inference, and it legitimizes the more general finding. Policy development and evaluation is another very important area, and last but not least, dissemination and implementation. And I would posit that a lot of the research in population health has focused on areas 1 and 2, and a lot less has focused on areas 3 and 4. And continuing to do what's important in 1 and 2, but also expanding into 3 and 4, I think is critically important. So etiologic in the broad sense. So what are the kinds of things that we've worked on so far? We've linked health to distal and upstream determinants, and I think there's been a lot of productivity in this area. I'm listing some here: income inequality, social capital, neighborhoods, racism, economic fluctuations. Now there may be debates about how important all these things are, and are they causal or not. But nevertheless, there's a large body of work that is focused on these kinds of domains with some, I think, important lessons. What are some directions in this area? Well, first, I think methods for improved causal inference are really important, and many of you in this audience are engaged in that. And so I think, this is a constant struggle in terms of being able to draw conclusions that are causal, because if we want to justify policy on the basis of them, we have to be able to make a causal argument. So I think things that we can do realistically with recognizing that we have to deal with very messy data And we have to make sense of that messy data, and it's our responsibility to do that, I firmly believe, as scientists. So we're not going to be able to do perfect causal inference, but we can do things that help us move in that direction, and the more we do of that, I think the better. Integration of new data, new types of data. I mean, you know, you've all heard about the many, we had a session this afternoon, many sources of data, very rich, you know, time-resolved, space-resolved data that we can now obtain, and that many places are generating just because, you know, it's possible to generate those kinds of data. Data on cities and how they function, the data on transportation patterns, et cetera. So I was thinking about how we can integrate that kind of information. This came up, I think, today as well. I mean, this idea that many of the factors that we're interested in are acting together, are cumulative, synergistic, and can't necessarily be teased apart. Neil Mehta presented something this morning, I can't remember, on how the number of risk factors has remained constant, even though the kind of risk factor has been changing. And I think we need to think about those behavioral factors and other factors in concert, how they act together. And for that, we need perhaps to think about these things a little bit differently. And I think here is where the tools of systems thinking and systems approaches can be helpful. And also, you know, keep our eye on the big questions. And I think we really have to continue to push to look at the sort of macro stuff. You know, typologies of urbanization. Cities grow and develop in many different ways. What are the implications of that for health in cities? Climate change, organization of work, cross-country comparisons, these big differences that we see across countries in health. Report a couple of years ago on the U.S. health disadvantage, and yet if we really, you know, look at what we know about why there are these differences, honestly, if we're honest about it, we just don't know. And I think focusing on those kinds of questions, the big questions, it remains critically important for population health. So that's etiologic in the broad sense. The second area is mechanistic, or sort of this, what I'm calling sort of legitimizing. And we have, you know, focused on understanding and often confirming proximal mechanisms. You know, this work started with behaviors. You know, 20 years ago, when people were looking at whether, you know, the social class differences in health were due to differences in behaviors, and you know, that was like a first step. And now, of course, it's the so-called biomarkers, and you know, blood pressure, weight, inflammatory markers, you know, CRP, et cetera. And more recently, it's manifested in epigenetics. And so I think this can be helpful, often doesn't always yield a lot of new insights, but it can be, I think, legitimizing and strengthen causal arguments for the more distal factors, and certainly over the life course as well. So I think there are, I think there's been a lot of work in this area already. What are some directions? Well, I think this idea of, and this relates to something I said in the, when we talked about etiology, this, you know, we've been looking at these so-called biological mediators kind of one by one, you know, is it this, is it that? And sometimes the results are maybe not that compelling and have a lot of methodological problems. But I think thinking about this more complex mediation, this idea that some of the patterns that we see are due to multiple factors operating, multiple mechanisms operating simultaneously. And you know, this idea that different people can get the same disease through different pathways. And so it's not always going to be the same mediators. And so, and again, there may be synergisms, interactions, there may be feedbacks. Behaviors affect stress, stress affects behaviors. And so thinking about, if you want to build a very solid, sort of basic mechanistic understanding of the drivers of population health, I think we're going to have to grapple with some of this more complex mediation idea. And closely linked to this is this idea of context dependency and plasticity, that, you know, that as I was saying, that there may be different paths to the same outcome depending on other contextual features. And so, and again, this makes us think about a more systems kind of way of thinking about the drivers of health. And also, this doesn't fit exactly within mechanistic, but it's related. And I think we also need to focus on how social determinants affect the process and outcomes of healthcare. And I think this came up in the session this morning. I think it's an area that the population health community has not focused on much, but I think being able to show how information on the social context, for example, can help us with risk prediction or predict outcomes of treatment or could indicate, the need for different kinds of treatment or complementary services is also, an important area. The third area I wanted to touch on is policy development and evaluation. And I think I think we have, the work so far there have been attempts to sort of understand and evaluate the health impact of various policies. And I think, we've looked at things like transportation policy, food policy, urban design, insurance reform. In my assessment, this work is still in its infancy. It's more limited than the etiologic work and the mechanistic work that we've been engaged in. And so I think there are lots of potential directions here, including broadening the range of policies that we look at: taxation, income redistribution, big picture urban planning and urban development kind of stuff, social policy writ large, broaden the tools, and there has been a push towards capitalizing on natural experiments a bit more. We have to continue to do that. It's not going to be perfect, but it can be very informative, and the systems approaches that I mentioned, including systems simulation modeling. And also, I think it's really important to remember that, I think there has been a tendency in academia in general, I think, to think of, there's research, and then the research leads to policy, and the policy happens, and then it's out there. But in fact, the research can lead to policy, and we can learn about fundamental things by evaluating the policy. And the need for the policy feeds into this research. So this idea of research to action and back, a different way of looking at the interrelationship between research and policy. And this came out in the session this afternoon, the terrific session on policy just earlier this afternoon. So a different paradigm where we're not just, there's this basic research and then that's going to somehow be used in policy and then it's out of our hands, but rather we as researchers, even if you're interested in fundamental understanding, you can learn from policy evaluation about those fundamental processes in ways that you could perhaps not learn in any other way. And so this bidirectional relationship. And of course that requires mechanisms that aren't necessarily in place today in academic institutions. And last but not least, dissemination and implementation research. As many of you, I'm sure, know, there is a big push at NIH, for example, for dissemination and implementation research. Unfortunately, it's very narrowly focused in a very clinical way. So it's about treatments, translating treatments into the clinical setting, and thinking about and disseminating that, and then implementing those treatments in various clinical settings. We have to bring the population perspective to this, because I think just like there are issues in dissemination and implementation for individual-based clinical interventions, there are issues for population interventions and policies as well. And so, and here, in terms of the dissemination piece, and I think this came up in Alonso's comments as well, part of it is changing the paradigm about what drives health and, what people think drives health. And even though we've been talking about a different approach for a long time, I would posit that out there in the public, there's still the perception that the main drivers of health differences are genes, behaviors, and medical care. And so thinking about novel uses of data to change perceptions about the drivers of health and the appropriate societal responses. So now that we have all this incredible data, are there some interesting new ways we can display that data or do things with that data that highlight the different way of thinking about what drives differences in health across people and across communities? Another area that I think is very interesting is, and this is borrowed from early from a field of systems modeling, which is participatory systems model building, in which you construct a systemic model with participation of a variety of stakeholders. And so the process of developing this model, which can be very illuminating for the researcher, but also for the stakeholders and the community, to think of, and these models often include things like feedbacks and dependencies, which we often tend to sort of conveniently ignore in a lot of the empirical analyses that we do. So I think that can generate new insights, both for the researchers and for other participants, into what some of the drivers of health might be. And it causes people to think about these things a little bit differently, which I think can be very illuminating. And then, obviously, thinking about the context dependency of policy effects, how policies, even the same policy can be implemented slightly differently in different places and yield different results, and what can we learn from that? For an example from urban planning, there's a complete streets policy that has been adopted by many different communities in the US, and yet it's being implemented very differently in different places. If we could capitalize on that and evaluate that, we would learn a lot just from that variation in the implementation of the policy in terms of what works and what doesn't work. So I think there are lots of ideas from this world of dissemination and implementation science, which I'm not an expert in, but I've gotten more interested in, that we can think about in population health, and really move it out of the purely clinical realm into the population and community realm. How am I doing on time? Okay.
3 or 4 minutes.
Okay, and also, of course, implications for health care in terms of some of these other factors, that social and economic context factors. What are the implications of considering those factors for the things that we do through the healthcare system? And this was the topic of today's panel this morning. The other big area, I think, aside from these sort of 4 types of research, I think there's still a lot of work to be done in terms of inequities. And certainly, there are 2 areas that I think are ripe for continued work. One is the causes of heterogeneity and inequities across contexts. I mean, we see remarkable differences in the magnitude of health inequities. Even within the US, there are large geographic differences and black-white disparities in many outcomes. Well, why is that? Why do we see those differences? If we could figure that out, we would know a lot about what drives those differences. So, and similarly, differences across countries or regions, for example. And although there has been, some work in this area, looking very specifically about how policies and practices affect health inequalities and the reasons why they affect them in the way they do. There have been attempts to do this, and there are some, there's some good research in this area, but I think we don't do enough of it because, as we know, sometimes a very good, well-intentioned policy has the unanticipated effect of increasing health inequities. And I think understanding why that happens can also help us improve the policy, or maybe come up with other policies that are effective at reducing inequities. And I think another area where I think we can in population health we can do better is replication and systematic summaries. I mean, in part because our topic is so complex, we have lots of different studies, sometimes with slightly different measurements, and it becomes challenging to summarize that work. Very challenging to summarize that work for academics and for policymakers, even more so. And for example, the geneticists are very good now at doing these consortia and doing replication. And clearly we don't have the same situation as the geneticists because we don't have SNPs which are measured the same way in every single person. We have much more complex situation. But I think we need to do more in terms of replicating and systematically summarizing our studies, and that means trying to make sure that some comparability of measurements or harmonizing of measurements, building larger consortia that can help us pull some of this together. In building this evidence, I think we need to think about different sources of evidence. Observation is important. Observation can lead to experimentation. As we now know, literature on neighborhood effects led to the moving to opportunity. The moving to opportunity suggested new areas for observation to try to explain the findings of the moving to opportunity, some of which were unexpected. I think systems simulation modeling can have can also provide additional insights, and the process of developing these models suggests the need for new observations to fill in gaps in our knowledge. Similarly, systems models can lead to experiments, and experiments can feed in. The results of experiments can help us improve these systems modeling approaches. So we really need, we're not going to get answers to these big questions by using a single approach. We need a multiplicity of approaches. And sort of combining these and triangulating them, or even quadrangulating them, because there is action in public health, and we often take action in the face of incomplete evidence. And so figuring out ways that we can that can be part of our evidence-generating system, the evaluation of action in an integral way, I think is another very important element. Okay, so I think I'm going to skip this, well, maybe I'll do it since I have. So I think there are a few misperceptions that we should overcome, at least in my view. So this idea that we're about the population, they're about the individual, that's not the case. We're about the individual and the population, and research should encompass that. The idea that we should only study the possible causal impact of what is manipulable, and that observational etiologic research is pretty much worthless, I think, is also a misperception, because obviously what's not manipulable today can be manipulable tomorrow. Making the healthcare system responsible for population health is the key. I think that's a misperception. At the same time, it's also a misperception that the healthcare system is irrelevant and that it's okay for it to ignore social context. And certainly research is not a key driver of policy, as we heard this morning. To finish up, I'd just like to end on this quote from Forrester, who's sort of one of the founding figures of systems theory, and he said, "In the complex system, causes are usually found not in prior events, but in the structure and policies of the system." And so I think this is the challenge in population health research, that we have to sort of disentangle the ways in which the system generates health and health inequalities. Thank you.